quickly as possible.
I think that's a great point. We underestimate the time that it's going to go. We'll start CRT at 3, but the reality is you get the line, confirm the line, and the whole thing, and maybe
right. And it takes an hour to set up, and then and then it's 3 a.m. and you're still staring at a scary looking potassium level.
Exactly. Very good. So I think we can move on to the next section. I think is highly anticipated. Thank you, Elliot, again for this fantastic lecture. Feel free to jump into the further discussion down the road in the next couple of lectures we're going to have. The next is a hot topic, but it's actually not a very hot topic because we're going to be talking about cooling or not cooling. We have designed this next session to be given by 2 fellows in training, mentored by 2 stellar faculty members, experts in the field of cardiac arrest. We're going to be talking about hypothermia, the name of to cool or not to cool, with the pro-cooling argument by Dr. Megan Burke, mentored by Dr. Ben Abella, and the against cooling argument by Dr. Jeffrey Lee, mentored by Dr. Andrea Elliott. We're going to be starting with the pro-cooling debate with Dr. Burke. Dr. Megan Burke is a cardiology fellow at the University of Pennsylvania in Philadelphia. She received her medical degree from Temple University and completed her residency in internal medicine at Penn. She's following right now a master's in translational research and is going to be starting an interventional cardiology fellowship in July. And her clinical interest includes cardiogenic shock and cardiac critical care. Megan was mentored by Dr. Benjamin Abella, who is professor of anesthesiology and critical care, has contributed a lot to the field of cardiac arrest. He's also professor of medicine and emergency medicine at the University of Pennsylvania, and the director of the Center of Resuscitation, the medical director of the Pain Acute Research Collaboration, and vice chair for research. This is a very nice moment for us to congratulate Dr. Abella because 2 days ago, he was named the William Bax Chair of Emergency Medicine at Penn. So it's a pleasure to have both Andrea and Benjamin here for the pro part, and then we'll move into the against part with the next 2 speakers.
All right, I'm going to go ahead and share my screen. Can everyone see my slides okay? Awesome, thank you. Thank you so much for having me here. I'm really excited to be part of this discussion. And as mentioned, I will be arguing in favor of cooling. I have no disclosures. Before I get into my main argument for cooling, I just wanted to lay out some definitions. So for the purposes of this talk, I am going to say that cooling is defined as any intervention we use to lower body temperature. Targeted temperature management is really the achieving of a specific body temperature as outlined in the studies that we'll be looking at today. And then I've highlighted here the definitions of hyperthermia, normothermia, and hypothermia, although generally, clinically speaking, as all of you know, we define fever as anything greater than 38 degrees Celsius for most patients. Now, we know that fever is bad for patients with neurologic injury, but the question that we ask ourselves, especially for the purposes of this debate, is whether hypothermia is better. Now, I'll start by going through some of the basic science literature. And there's an abundance of data that shows in preclinical animal models under a variety of conditions that cooling to hypothermia compared with normothermia does portend a benefit when it comes to both survival as well as neurologic outcomes. Now, you can say that animal models are not always a good surrogate for patient physiology and behavior, human patients. But when it comes to cardiovascular physiology, actually animal models, time and again, have been quite good surrogates for cardiovascular physiology. So it shouldn't be discarded that there is an abundance of data here, and it all is very strongly in support of cooling when compared to normothermia. Now, that leads us to a discussion of the human data, and I'll focus here on the randomized controlled trial data that's available. And I've created this table that summarizes the major randomized controlled trials in this field that have looked to answer this question. And that starts in 2001 with a trial that came out looking at, it was a small trial with about 33 patients looking at normothermia compared to cooling to 33 degrees. And they looked at survival at discharge, and there was no difference seen between the groups. And then in the year 2002, we had two trials that came out, both looking at cooling to hypothermia compared to normothermia. These patients were out of hospital arrest patients. They were patients that had shockable rhythms. Both of these studies look at survival with neurologic outcomes. The HACA trial looked not just at discharge, but also at 6 months later. And both of these trials did show a benefit, both when it came to survival and neurologic outcomes with cooling compared to normothermia. So it was over 10 years before we had our next trial, and that was the TTM trial, which was a pivotal trial. And I will say, compared to the previous trials, it was not looking at hypothermia compared to normothermia. It was looking at the comparison of two hypothermia groups targeted to 33 degrees Celsius versus 36 degrees. Now, these patients, again, out of hospital arrest patients, there were high rates of VT-VF among these patients. This study looked at all-cause mortality as well as the primary outcome, as well as a variety of composite secondary outcomes. And they saw no difference between the two hypothermia groups. In 2019, we had the Hyperion trial. This looked at hypothermia compared to normothermia. And this study was a departure from the previous studies because it looked at patients with non-shockable rhythms. It looked at survival and CPC scores, which are a surrogate for neurologic outcomes. And this study showed no survival benefit, but it did show that patients had better neurologic outcomes in the hypothermia group. And then lastly, that brings us to 2021, where we had the TTM2 trial. This was another very pivotal trial. This trial was done by the same group that did the TTM trial. And here they were asking the question whether hypothermia patients had better outcomes compared to normothermia. Similar patient population to the TTM trial, also looking at survival at 6 months, as well as a surrogate for neurologic outcomes. And here again, they saw no difference in survival or functional outcomes. So when we look at all of these trials, the data is clearly mixed. And the TTM2 trial and the TTM trial are really two very well done trials. I'm not here to poke holes in the way these trials were done. They were very well done. They were very rigorous. And these trials were used and have been used as support for the argument that we should not be cooling patients to hypothermia. But with any trial that comes out, we need to ask ourselves, do the results of these trials or this trial generalize to our patients? And so I'm going to take you through what these patients looked like in both of these trials. And again, as mentioned, they're very similar. These patients had very similar demographics in both trials, but I will highlight for you, and this stood out to me when I read these trials, that these patients had high rates of witnessed arrest. They had high rates of bystander CPR and high rates of shockable rhythm. And when I look at those numbers, I do not see those rates of witnessed arrest, bystander CPR, or shockable rhythms that come through our hospital in Philadelphia. And I hope you're all asking yourselves the same thing when you see this data. And I'll also highlight that these patients had pretty low rates of shock, high rates of ST elevation, MI, and interventions. And that makes sense given the rates of shockable rhythms. But to me, these patients don't seem as sick as the majority of patients that certainly I see with out-of-hospital cardiac arrest. And I think then we have to ask ourselves, while these results were good results for these patient populations, what about patients that are sicker that we see day to day? And so I have this table here to show you the rates of bystander witnessed arrest, bystander CPR, shockable rhythm, and survival in the TTM2 trial compared to 5 cohort studies here in the US. And this really does suggest that the patients that we see in the US have lower rates of witnessed arrest, lower rates of bystander CPR, lower rates of shockable rhythm, and as we know, all of those things portend worse outcomes, lower rates of survival. And so this is more representative of the patients we see in the US compared to TTM2. Now, that may be because the patients in TTM2 were a highly selected population for the criteria that they chose to include. It also speaks to the different systems of care that exist in Europe compared to the US. But the patients in TTM2 are not the same patients that we see day to day. And so if the patients that we're seeing may be a little bit sicker, then you can ask if sicker patients have greater benefit from cooling to hypothermia. And these two studies set out to answer that question. One of these studies was done here in the US, the other was done in Japan. Both saw greater benefit for cooling with sicker patients. This is from the study that came out in the US, and I won't go through all of the details, but I'll highlight here that for patients who had increasing illness severity as demonstrated by survival and neurologic outcomes, the sicker you were, the more likely you were to benefit from cooling to hypothermia, 33 degrees here compared to 36 degrees. And the study in Japan found the same thing. They used different measurements here for neurologic outcome and survival, but you can see in the low illness severity group, there was no benefit, but in the moderate severity group, there certainly was a benefit. And I will say, although there was no benefit in the high illness severity group, as we've seen time and again, the sickest patients, it's very hard to demonstrate a significant benefit with any single intervention. So lastly, I will speak to what does it look like reacting to these trials in real time. After the TTM trials came out, a lot of institutions said, okay, we're going to change our protocols from cooling to 33 degrees to 36 degrees. And a couple studies came out showing the data of what that looked like after these institutions implemented those changes. And a couple of these studies did show that after they made those changes, they found that patients did worse. So this study that came out showed that at this institution, after they made that change, the patients that were cooled to 36 degrees compared to those who were cooled to 33 degrees had worse neurologic outcomes. So I will end there by saying, in summary, that we have a lot of evidence from preclinical data that supports cooling to hypothermia. We have 3 positive randomized clinical trials that shows that cooling to a target of 33 degrees does improve outcomes. We have 1 study comparing hypothermia to normothermia that shows it does not improve outcomes for those patients who were not as sick as we see in the real world. And then the real world experience that once we switch from 33 to 36, some studies did show that there were worse outcomes in retrospective cohorts. And then lastly, we have data that suggests that sicker patients are more likely to benefit from cooling than those who are less sick. And lastly, I'll say that cooling as an intervention overall has quite a low side effect profile. The TTM2 trial did show that patients in the hypothermia group had higher rates of arrhythmia, but this did not portend any change in neurologic or survival outcomes. So I'll conclude by saying that for an intervention that has a highly favorable risk-benefit ratio, and in patients who are very sick where the stakes are very high, I think cooling is a no-brainer. So I'll end there.
Thank you very much, Megan. So now we're gonna move towards your review with Dr. Jeffrey Lee. Dr. Jeffrey Lee is a general cardiology fellow at Maimonides Medical Center. He has completed his internal medicine and residency and fellowship training at Lenox Hill Hospital, and he's going to be starting an interventional cardiology fellowship at Stony Brook this July. He's a talent pianist, I recently learned, and he also speaks several languages. Dr. Lee is going to be mentored by Dr. Andrea Elliott, who is a critical care cardiologist at the University of Minneapolis. She has a special interest in critical care cardiology education, especially fellowship education. She completed her medical school at the University of Texas in Houston, and residency in internal medicine and cardiology at Pittsburgh, and then and critical care at the University of Minnesota. So we're gonna go now with the review of why we shouldn't be cooling patients, against cooling argument.
All right, good evening, everyone, and thank you for that very nice introduction, Dr. Alviar. Can you all see my slides okay? All right, excellent. So it's a real pleasure to be presenting for you today and to be part of this program. Our team has been tasked with convincing you why we should not be cooling patients post-cardiac arrest. All right, so obviously that's a very tough act to follow, courtesy of Dr. Burke. But I have every confidence that when we do review the data, I'll convince you in favor of not cooling patients to 33 degrees post-cardiac arrest. It was also a pleasure to work with Dr. Andrea Elliott on this presentation. We had a lot of fun putting this together. I have nothing to disclose. So first, I just wanted to talk about hypothermia as a broad concept. So when we look at how to improve survival post-cardiac arrest, naturally one might assume it's to improve cardiac function. But the data actually shows that once you get ROSC, cardiac function actually recovers, and only a small group of patients will actually die from cardiac disease. Most will actually die of neurologic complications as seen here in this small trial. But there's data behind it, behind wanting to intervene and to mitigate brain injury post-cardiac arrest. So I guess that's why we're here. The good thing is there's a fairly large body of basic science literature to support the biologic plausibility for cooling in post-cardiac arrest patients. I'm not going to go fully into it because it's going to take much longer than I have, but basically it was supported in animal studies that hypothermia does decrease cerebral oxygen demands, which is supposed to help alleviate the ischemia that occurs after cardiac arrest, and I think we all know that. But at the same time, these animal models show that many of these enzymatic reactions are affected, not just the neurologic ones. Remember, enzymatic reactions in our body have kind of formed over time to function at our normal body temperature. So hypothermia in and of itself is a blunt tool with a very wide possibility of outcomes. You may be slowing down inflammation, but you're also slowing down anti-inflammatory pathways that are protective in the setting of, say, like infection. Hypothermia will reduce intracranial pressure, but you might end up reducing the blood pressure. And in turn, maybe you're reducing cerebral perfusion. But we don't have to speak in hypotheticals. I'm going to review these two studies with you, the TTM1 and TTM2 that Dr. Burke already discussed. Remember, both trials investigated the outcomes of patients who underwent hypothermia post-cardiac arrest versus just maintaining euthermia at 36 degrees. So TTM1, remember, is a very well-powered randomized control trial. They enrolled 950 patients all out of hospital cardiac arrest. They excluded patients with greater than 6 hours from ROSC to enrollment screening. They excluded patients who were unwitnessed arrest, hypothermia if they came in cooler than 30 degrees already, if they had suspected or known intracranial hemorrhage. So the groups were randomized to either temperature, targeted temperature management of 36 degrees or 33 degrees. And the primary outcome was survival, and the secondary outcomes were neurologically favorable outcomes, and there was no difference between two groups, as we saw earlier. As we know, there are well-documented adverse effects that are seen in severe hypothermia, but there was virtually no difference in adverse event outcomes observed in these two groups here. Hypokalemia in the hypothermia group was the only significant finding in TTM1. So at the end of the day, the trial asked if there was a benefit to cooling patients to 33 degrees versus maintaining normothermia at 36 degrees, and the outcomes among the two groups here were essentially the same. Again, this study was well designed, and they enrolled plenty of patients, and the objective outcomes were assessed by blinded external physicians, which I think is a very important point to make here. And this trial was larger and more robust than any prior hypothermia trial that had come before it. So after TTM1, we continued to cool patients, right? So 2015, the AHA guidelines left it open. They said that physicians could still continue cooling if they saw fit. So in the meantime, the TTM group went back to work, and they continued to grow the number of patients being investigated. And they came back in 2021 with this TTM2. TTM2 was another large trial. This time they enrolled close to 2,000 patients. It was very well done, controlled for many aspects that they had in TTM1, and this time with very limited criticisms. The investigators didn't take any chances. They blinded everybody. They blinded prognosticators, outcome assessors, the team, the coordinating team, statistician, even the families were blinded. So I think only the clinical team treating the patient directly was not blinded to the treatment randomization. And this time, all patients received neuroprognostication at 96 hours by a blinded physician. And again, no difference in primary outcome, which was death by any cause at 6 months. There were no differences in the two groups with respect to functional outcomes at 6 months either, only the increased risk of arrhythmia in the hypothermia arm, as Dr. Burke mentioned earlier. So key points here. This was another large trial, close to 2,000 patients. Remember, it was 900 in TTM1, and it was actually just 300 in Haka and Bernard combined. So this was a very large study, very well designed. And I think they were more aggressive at addressing the status quo as well. They were comparing hypothermia to just aggressive fever control. If a patient's temperature went above 37.8 degrees, they cooled that patient to maintain euthermia. And in an effort to limit bias, remember again, they did neuroprognostication at 96 hours with blinded clinicians. So I think this was a vast improvement. So after all that robust data, if you're still hanging on to hope that the Bernard, from the Bernard and Haka trials in the 2000s, let's talk about the staggering number of limitations in those trials as compared to the more contemporary TTM1 and TTM2. So the Bernard randomized control trial was small and it had a very high risk of bias. They randomized only 84 patients and only VF patients, VF arrest patients actually. And it wasn't a true randomization, it was more pseudo randomization. If it was an odd numbered day, you'd get hypothermia, and if it was even, then you wouldn't. It was unblinded, and we know that performing therapeutic hypothermia takes a lot of time and attention at the bedside. So, you know, if someone isn't blinded to that treatment and they see that that patient's getting that kind of care, maybe they get more attention, they get more management, more diligence regarding their care, and maybe that could affect their outcome as well. The Haka trial was another small trial with a lot of bias as well. They only randomized 275 patients, witnessed cardiac arrest with only shockable rhythms. Doctors and patients were not blinded, and many of the patients in the control group actually developed fever. So maybe, I'm just postulating, but maybe the hypothermia was effective or more effective just because it prevented the fevers. Or conversely, maybe the patients in the control arm did worse because of the fevers. Maybe the hypothermia just made it look better. We don't know. So lastly, after all of that, if you should still choose to cool, remember there's a real cost of cooling, and there are a lot of potential harms to these patients. You know, you all know this already, but you know, we've witnessed this in practice. You can get bradyarrhythmias that cause hemodynamic instability. You could get cold diuresis. These patients lose a lot of volume and they become very hypovolemic. You get electrolyte abnormalities, hyperglycemia, increased risk of infection, more specifically pneumonias, coagulopathies, you name it. But so there are a lot of risks here. But takeaway points. So from all of this, what I want you to take away is that the Haka and Bernard trials were very small with a lot of limitations. There were two very robust trials that came along later in the 2010s that showed no benefit to hypothermia. So maybe it's an unnecessarily aggressive approach with a lot of costs and a lot of potential harms. Maybe we should just consider treating fevers more aggressively. And I'll leave you with this, but think about this. What if TTM1 and TTM2 had come out before Haka and Bernard did? Would we even be having this debate at all? Here are my references. Special thanks to Dr. Elliott, Cheryl Sidney, and my dog, Ruth. Thank you, everybody, for your time.
Thank you very much, Jeffrey. That was very good. So now we're going to move into the debate, and our moderator tonight is going to bring the questions and generate a very nice discussion. Dr. Stephen Hollenberg, he's a professor of medicine at Hackensack Meridian School of Medicine at Seton Hall University. He's also the associate director of the Cardiothoracic Intensive Care Unit and the program director of the Cardiology Fellowship at Hackensack University Medical Center. Steve is also transitioning. He's now taking a new position as the director of cardiac critical care at Emory Heart and Vascular Institute. He's going back to his alma mater where he completed his medical school. Steve has been instrumental in also the development of critical care cardiology as a specialty. We happened to meet randomly one day at the ACC, I think 2017-18, when there were no buses going in Chicago to the medical center, and we hopped into a cab together and we're going to the same session. And since then he's become a friend and a mentor and a pleasure to work with. So Steve, please take it on the debate, and we look forward to a great discussion.
Thank you, Carlos. It's a pleasure to be here. I have at least one former fellow in the audience, and a colleague in residency was the father of one of our debaters. I know Jim Burke quite well, actually. I just thought I'd start out, and we'll take some questions from the audience. I think the first thing to say about the trials is that neurologic outcome is really important. I know people have skepticism about these combined outcomes of death plus neurological, but in this field, it's really important because survival to a nursing home doing nothing is not a good outcome. So I really do think all these trials have looked at both survival and neurologic outcome. Cardiologists tend to frown a little bit on these combined endpoints, but you can't do that in this field. You have to think about neurologic outcome, and that plays into it. And then, maybe a little bit of a historical point of view, all the preclinical data was done when you guys in the audience were about 3, right? And they all look good. It made a lot of sense. And then the Haka and the Bernard trials came out, and they were positive. Everybody thought it would work. It made a lot of sense. And they were positive. We went, great. Now we actually have something to do for cardiac arrest. And not only that, the critical care people got involved, right? The cardiologist didn't really know anything about cooling. So you called the critical care person, he said, and he or she came and said, we're going to come, we're going to help you. This is cooling. This is great. We have the Arctic sun. We know how to turn it on. We'll tell you all this stuff. And all the conferences went, now we have a therapy. Now we have a therapy. Now we have the chain of survival and all that stuff. But when they get to the hospital, now we have something we can and should do. And I'm only being slightly facetious because this translated into programmatic changes. You had to know how to do cooling. You had to do it quickly. It turns out it may or may not matter that you do it quickly, but you had to know how to do it, and you set up programs to do it. And that's still true today. If you're going to do it, you're going to want to have an institutional setup that allows you to do it with some frequency and with some skill. And then, the Haka, as been mentioned, the trials were a little bit small, and there was that fever in the other groups, and there was a question of whether the effect was avoidance of fever. There was something there, but whether the effect was avoidance of fever or whether it was actually cooling. So TTM1 came in and said, okay, we're going to deal with all these objections. We're going to look at avoidance of fever by going to 36, and we're going to compare that to 32, and we're going to avoid the fever, and we're going to call it therapeutic temperature management, because I think everybody in the field definitely agrees that avoiding fever is important. And to some extent, a program that controls temperature, where everybody thinks about temperature all the time and make sure the patients aren't febrile. However that's accomplished, and whatever temperature, everybody agrees that you shouldn't let the temperature go out to 38 degrees. So that was TTM1. So then we were still saying, well, and we'll get into splitters and lumpers in a little bit. And then there was a Hyperion trial that said, well, the survival wasn't the same, but the neurologic outcome was better, and it was non-cardiac arrest. There was and still is debate about, the idea was that the shockable rhythms were going to do better, but even in non-shockable rhythms, at least some signal of neurological benefit. But the cardiologists basically were saying, you're to the critical care people, you did a couple of dinky trials and it didn't work. And now we got a big trial that doesn't work. And here TTM2 comes, it's twice as big as the last big trial, which in turn was 3 times as big as the first trial. And it didn't show anything. So you still have you have this you have the situation. I'm sort of in the situation that I usually am at the end of the debate. I hear the first speaker, I say, yeah, she's right. And I hear the second speaker, I say, yeah, he's right. And then at the bedside, the nurses or the program says, should we do this? I still think there is room for uncertainty in this field. And I think some of it comes down to philosophy about whether you're a splitter or a lumper. So if you're a lumper, you say we've got large randomized trials that show on balance that you can't really show an effect. And when my when the bean counters ask me whether we should spend the budget to do this, and they show me big trials that say it doesn't seem to make any difference, it's a little difficult to argue with them. On the other hand, it is a selected population for the reasons that Megan laid out. It is a little, and you have to admit the possibility that there are some patients who may actually have some benefit. And you sort of want to, the challenge here is that you have to find the happy medium. If they're not sick enough, they're going to do well no matter what you do. If they're too sick, they're going to do poorly no matter what you do. So you want them sick enough to benefit, but you don't want them so sick. And Megan showed those data. It's the intermediate group where it might help, and you might think that you'd be more likely to do it in a 40-year-old. You might be more likely to take the trouble in a 40-year-old than you would in a 92-year-old, and this and that. So I'll admit to some lingering uncertainty on this issue. I do think it's easy to say we need more data, but we probably need more data. But it's hard to imagine that we're going to get a lot more data early. It is true that the Europeans do a lot of things better than we do, including getting to people quickly and doing bystander CPR, and they send the defibrillators out on drones and stuff like that. It's all this really cool stuff. And our response times for EMS are in the 7 and 8 minute realm, except in some cities who seem to do it better, like Seattle or Rochester, Minnesota, for example, or to some extent Tucson, Arizona, I believe. So there's some uncertainty there. And I do think that thinking about programmatic issues is worthwhile. You sort of have to decide whether you're ever going to do it. So if you get to the point, if you say you're never going to do it, then it's fine. Nobody has to know how to do it. But if you're ever going to do it, then you need to think a little bit about maintaining an institutional protocol for how you're going to do it when you want to do it. Who is doing this? It's usually a critical care consult in the CCU, but sometimes the CCU gets good at it. And if they do enough of it and this and that, I think, to my mind, it's probably worthwhile remembering how to do this, because who knows what the next trial will show.
These are great points, Steve. I would like to actually pose a question for the three faculty members, and also fellows feel free to jump in, but for Dr. Avella, for Dr. Elion, for you. Do we have a problem in understanding who are the right patients to be selected for these trials? Because I'm a firm believer, based on the data, and there's also the meta-analysis on these animal studies that were done in animal models of cardiac arrest. The more severe ones had better outcomes with lower temperatures.
Yeah,
a trial that comes with patients like that. So what do you think of that?
Well, if I could jump in, yeah, I think you're asking the right question. I think this is all about patient selection. And, one fundamental point to make to the fellows on this call, size of the study is important. And I agree with Jeff's points about size and rigor. These are rigorously done studies, but size and rigor are not everything. Generalizability is a key issue. And I think my former colleague and superb fellow, Jeff, made very good points about this, the power of these trials, but you have to look at who they enrolled. I'd be curious to know how many of you, this is a rhetorical question, have 40% PCI rates in your post-arrest patients, or lactates of 6, or 90% witnessed arrests. I don't see it. Most places I know don't see it. So I think both are right. And I think here's one way to put this in a critical care lens. If I were to ask all of you erudite critical care doctors on this call, hey, I'm a med student, I don't know, should we do for sepsis, vasopressors or no vasopressors? Which is it? You'd say, gosh, that's like not a great question. For whom? Like which patients, right? It's not that vasopressors are good for all patients or none. we all know that there's flavors of sepsis that fluids and antibiotics do the trick. And we all know there's flavors of sepsis that they don't do the trick, that you need pressors. I think it's the same. I think this is about patient selection. And so to your question, if we follow what's been done retrospectively, which is the Pittsburgh and the Japanese study that just came out within the last year, they use different scales for severity, but it's pretty clear that this injury severity, as Pittsburgh defined it, was based on sort of end organ injury. As Japan designed it, the Japanese RCAS scale included lactate and whether there's CPR performed or not. So they're both sort of, whether bystander CPR is performed or not, sort of a surrogate marker for injury. But fundamentally, we don't know the answer to your question, unfortunately. That is to say, we don't know what specific patients, what specific selection, what specific criteria should be used. But I'm getting the general flavor from the literature that TTM1, TTM2 didn't show benefit because in general, their patients were less sick. Other studies showed benefit because in general, their patients were more sick. So there's something there in my mind. And I think the next big phase of work is going to have to figure out the answer to your question.
Excellent. I think that's an excellent point. I don't know if Dr. Riley has anything to
add. Yeah, thank you. I actually put a few points in the chat there to keep that going too, but I couldn't agree more that it's really about patient selection. I mean, what I said in the chat was that while Jeff and I's point was to counter cooling, I have a large population of eCPR patients that have a downtime of 60 minutes, and almost every one of those are cooled. So, my patients I cool frequently. So while we made this argument, I think what we're trying to illustrate here is the literature we do have that is randomized. The strongest literature we have says in those that don't have deep injury, if you can call someone that had a cardiac arrest not deep injury, that there's no benefit. Now, does that mean that no groups benefit? No. So I think, just to reiterate and summarize in a different way, that I think moving forward for post-cardiac arrest patients will look towards some version of personalized medicine where we look at lots of different factors. It's not a one size fits all for every cardiac arrest.
I think that we can all agree on that, and individualization is going to be the most important aspect. Any other closing remarks? So we should still cook cooling, but the question is understand their patient population, understand the individualized, and really see what the differences are and how you can tailor this to the trials. I think we have a difficult task, which is convincing our skeptical colleagues. And I think if we do a simple study of doing a survey for neurointensivists, critical care specialists, and cardiologists, we're gonna see a huge difference in who is interested in cooling or not. Fantastic. Any other remarks before we close the session of the debate?
Yeah, just one last thing. I think it's important not to be dogmatic about this. I think it's important if you're gonna do this, you should say something like along the lines of, I know the data aren't so great, but I think given the right patient, there is some suggestion that. And if you're not going to do it, you say, the data don't really support it, but I can't rule out an effect in some people. I'm not saying that it's unreasonable to do it. I just don't think this particular patient can benefit. And we're all waiting for more data. Otherwise, it gets a little bit ugly. Why didn't you do this? Oh, no, sorry.
And I think also the volume and the centers, as you mentioned, if you do it frequently, you understand better the protocols. There was a recent meta-analysis in CERC, I think December, that showed that cardiac arrest centers have much better survival because we don't give up as easily, right? And when we argue about the safety of this is, yes, we have higher rates of arrhythmias, which is mostly bradycardia and some hypotension that sometimes the sedation has to do with it, but it didn't translate into higher degrees of shock or higher mortality. So I'm actually very comfortable somebody who is bradycardia needs a little bit of norepinephrine, but it's still a safe therapy to apply to this patient. And
yeah, I guess I have one more thing to say, and there's actually some the one thing to know for the fellows is that the neurologic prognosis, so in general, meaningful neurologic prognosis after cardiac arrest should not be made before 72 hours in all comers. And the available data suggests that with cooling, that period of uncertainty may go further. And nobody knows exactly how far, but maybe more than 72 hours, maybe this, maybe that. And there's some recently troubling data that suggests that many patients after cardiac arrest have comfort care in the first 24 to 48 hours before most of us think a reasonable neurologic prognosis can be formed. So you really have to wait it out once you start. And that, to some extent, may actually be the biggest potential downside in terms of resources with hypothermia, because it means you're going to wait longer for a definitive neurologic prognosis.
Absolutely. Thank you, everyone. There's been a great discussion. I think it's, again, very hot topic, and we hope to continue having some more nice interactions in the near future. So now we're going to move on to the last session of the